Hello, my name is Jan Blatnian. I'm a hematologist from Brno in Czech Republic. And in further 15 minutes or so, I would like to share with you the opinions on the prophylaxis in patients with hemophilia. What is haemophilic arthropathy? It is the joint damage caused by repeated bleedings into the joints, and currently it is one of the most disabling and most long-term consequences patients with hemophilia must face. It is obviously less frequent in mild and moderate diseases than in severe hemophiliacs, and this idea is behind the prophylactic treatment, because if you, by means of prophylaxis, change the severe hemophiliac into the moderate hemophiliac, the number and severity of the bleeding episodes is significantly lower. When talking about prophylaxis in hemophilia, we should mention it by definition that this is a treatment by intravenous injection of factor concentrate in anticipation of and in order to prevent bleeding. It was firstly mentioned, evaluated and reported in Sweden about 40 years ago, and nowadays it should be, and it is, the gold standard in the treatment of children with severe hemophilia worldwide. When talking about prophylaxis, we should mention the categories of prophylaxis. There are mainly two of them. Primary prophylaxis, which should start prior to development of any joint damage, and thus it should start before second year of life and before second bleeding. Secondary prophylaxis is started after onset of joint damage or after significant bleeding. From that point of view, it's clear that any prophylaxis started after multiple bleeds must be considered secondary. It is also well known that the longer the prophylaxis is postponed after the first bleed, the higher is the risk of arthropathy. On the right side of the slide, you can see the boy with two target joints. His knees are significantly changed by the haemophilic arthropathy. This picture is about 22 years old, and currently, if we treat hemophiliacs properly, if the patients with severe hemophilia or if the children with severe hemophilia are on prophylaxis, we should never see again the pictures like this. When we are talking about the prophylaxis, we should mention available regimens, and we should be able to choose the best one for our patient. There are many of them, but I would like to mention at least the three major or the three most frequently used. The oldest one, the original one, is the Swedish model, with its yearly and perhaps progressive start, where age is more important than intensity of the treatment, and with a recommended dose of 20 to 40 units per kg, administered twice per week in hemophilia B and 3 times per week in hemophilia A. A little bit different is the Dutch model, saying that it is not this model is not that strict, so it's not saying that you should start at a certain age with your patients, but it's saying that prophylaxis should not be postponed after the first bleed. With this model, very often lower dosage might be sufficient to prevent joint damage, and this model is also talking about something called tailored approach, because it's known that certain patients might do well treated on demand only, and some of them really need prophylaxis, and the doses might be different for different patients with different phenotypes. Then there is one of the Northern American models, the Canadian model, where saying that most boys will benefit from tailored prophylaxis. So again, it's not that much strict. With this model, less factor VIII is used compared to traditional prophylaxis, and this model is starting with the lower dose, and based on certain schedule, on certain scheme, it's increasing the dose and frequency, so it is escalating the dosing regimen in accord with the frequency of bleeding. So if it is required, it's escalating the doses. So this is meant by saying that it is patient-tailored. Having said this, I should also say that it is the model with probably one of the highest cost-benefit ratios, and it's attractive especially when the resources and concentrates availability are limited. Apart from those traditional ones, there are new emerging or promising prophylactic models, and I just would like to share with you one of them, which was recently published by German colleagues, and the motto for that regimen would be tolerate and protect. So this regimen was focused not only on preventing the haemophilic arthropathy, so preventing the damage of the locomotory apparatus, but also the intention was to decrease the risk of inhibitor development. The study mentioned on the bottom of the slide compared the control or historical group treated with the standard prophylactic regimen used in past in Germany, which was 40 to 50 units per kg 3 times per week, and this regimen was started after several bleeds, and it was compared to the new prophylaxis regimen. This new prophylactic regimen looked like described on the slide. So this axis is showing the age, there's the bleeding episodes, prophy regimen, and factor VIII exposure days. From this you can clearly see that as the child is growing older, around 10 months when scrolling and trying to stand up, there are first soft tissue bleeds. At that time point, very low dose and very low frequency prophylactic or prophylaxis regimen is started. It's just once per week, 20 units per kg. For a certain period, this very low dose, low frequency regimen is enough to keep bleeds under control. Once the child is more active, around 2 years of age, the first joint bleeds appears, despite of the regimen already in place, and it is the time point where the dose and especially the frequency is escalated. So it's changed to twice per week, 25 units per kg, and then if there are another breakthrough bleedings, it's going up to the standard regimen 3 times per week, 25 units per kg. Here you can see that till 10 months there are no exposure days, no exposure to factor VIII. This period from 10th to roughly 20 months, there is the patient is regularly exposed to relatively small amount of factor VIII, and it seemed that this works like some sort of tolerization phase. So it makes, or it is able to get the body used to the factor VIII administered. And after that tolerization phase, when there are breakthrough bleeds, which appear very often around the 50 exposure days, it is switched to the standard prophylactic regimen, which they call the joint protection phase. If you compare both control group and the study group in the German study, published recently, you can see that the demographics in both centers, as well as the genetic factors, have no statistically significant difference. There was also no difference between the product type used, the age at the first exposure, reasons for the first exposure, total exposure days, the number of surgeries during the study period, and there was also no difference in the vaccination. What was significantly different was, of course, the age at the start of prophylaxis, because the new regimen started much sooner, around before the first year of life. However, the original start of the standard prophylaxis was around 20th month. And it correlates with the number of exposure days prior to starting the prophylaxis. And there is the major outcome of the study, highly significant difference between the inhibitor development within these two groups, showing that there was much higher percentage of the inhibitor patients or patients who developed inhibitors in the control group compared to the study group. And in fact, the only one patient who developed inhibitors in the study group was the low response inhibitor. I'm not saying that this is well-established protocol. I'm just saying that the prophylactic protocols are evolving, and perhaps this promising protocol being confirmed by further studies, randomized and ideally multi-center studies, might bring another benefit to our patients.